Hello, and welcome to Anaphylaxis UK's Let's Talk About Allergies podcast, where we provide expert answers to common questions about allergies and anaphylaxis. Our goal is to offer valuable insights on how we can all work together to make life easier and safer for those living with allergies. In today's episode, as part of Anaphylaxis Awareness Week, we're exploring one of the most talked about developments in food allergy care, immunotherapy for food allergies. Immunotherapy can take different forms. The one most people have heard of is oral immunotherapy, or OIT, where very small, controlled amounts of an allergen are eaten to build tolerance. But there's also sublingual immunotherapy, or SLIT, where the allergen is placed under the tongue. So what do these approaches actually involve? Who are they for? And why aren't they widely available in the UK yet? There's a lot of information out there, but also plenty of confusion. To help us make sense of it all, I'm joined by Dr. Helen Evans-Howells, GP with a specialist role in allergy, Chair of Anaphylaxis UK's Clinical and Scientific Panel, lecturer at the University of Southampton, and founder of Dr. Helen Allergy Clinics in Ringwood and Belfast. Together, we'll unpack what immunotherapy is, who it may benefit, why access in the UK is still limited, and what the latest research tells us about safety and effectiveness. So whether you're a parent, an adult living with allergies, or simply interested in new developments in allergy care, this episode will give you a clearer picture of where things stand with food allergy immunotherapy today. Morning, Helen. Thanks for joining us today to talk all things oral immunotherapy for food allergies. So through our helpline, we often hear from people who've read about oral immunotherapy in the news or online, and they are often unsure if it's a cure for allergies or not and how it works. So I thought we should start right at the beginning and cover what oral immunotherapy actually is and whether it is a cure for allergies.
Thank you, Mary. Thanks for having me today. Okay, so I think the important thing to probably start off with is some basic terms so that people know what we're referring to when we abbreviate things. So we often refer to it as OIT, which might stand for oral immunotherapy or could stand for oral induction of tolerance. And we also have a separate treatment method called SLIT, which is sublingual immunotherapy. So the basic premise of both of those treatments is that we are trying to build up how much of a person's body could be exposed to a food group before a reaction occurs. So let's take peanut because it's probably the most studied form of oral immunotherapy. We are trying to expose that person to, in the case of oral immunotherapy, increasing amounts of peanut so that in time they would be able to be exposed to a set proportion without a reaction occurring. And that's called tolerance. It's not a cure because if it was a cure, somebody could eat as much peanut as they want without a reaction occurring. They could eat it one day and not the next. They could maybe avoid it for years without a problem and then eat it. And they could eat as much of it as they want without any rules around the dosing. There are some thoughts that perhaps if oral immunotherapy is undertaken early enough in a child's life, so perhaps within the first few years of life, maybe it will actually push to a cure and we might see permanent change within that person's body. And really that's around the fact that younger children's immune systems are much more modifiable, so they're more flexible and they change. We know babies, recover from things very well, and we see that with allergies. So if we started oral immunotherapy early in a child's life, it might create a cure for them. But there are very limited studies around that. So although there is one study for peanut, which shows that normally a person with a peanut allergy might have, say, a 20% chance of outgrowing it. So 1 in 5, so that's not nothing. Usually by around school age, this study increased their chance by another 50%. But the numbers when we're talking about most research around immunotherapy is really small. And so I believe that there is going to be more data looked at around this. So in other countries as well. And I think there will be a centre in London looking at if you start immunotherapy early in life, what are the rates of how many children then outgrow that? The challenge we have with oral immunotherapy of knowing have you cured or have you not is that in time, we do expect that the skin prick tests and the blood tests will start to come down. In the beginning, they quite often go up because you're now being exposed what you're allergic to. But over time, those numbers will come down. And we can be left in a position of thinking, well, is this allergy gone? Has this child, because we're often referring to children, outgrown their allergy, or does it still exist? Or is it that we've created a position of tolerance, i.e. because you're eating this food every day, your body's not reacting, but if you now stop eating altogether, will you revert back to a position of starting to have an allergic reaction? Really what we do then is we come to a position with that person and their family to say, would you like to have a trial off eating it? And we tend to take that for around 3 months where they don't eat the food at all that we've treated. And then we re-challenge them with it to see, are you still not reacting? And if that's the case, we tend to then call it sustained unresponsiveness, i.e. you don't have to eat this now all the time to be able to not trigger an allergic reaction. But of course, there are some unknowns still around that, like, well, how long is it that you could leave off eating before you revert back to reacting again? But for me, I feel that if somebody's blood tests and skin prick tests are now negative, and we achieve sustained unresponsiveness and the tests remain negative, then I think that's as close to a cure as we can get, really.
Sure. So why is there such limited data on immunotherapy currently?
There is a fair amount of data, Mary, to be honest. I mean, I find it staggering now, having worked in allergy for sort of 10, 11 years. So I first went back to university because, as you know, my background is as a GP. And because my son had allergies, I went and retrained. And so I was studying my allergy masters when I was pregnant with my third child. So I know how long ago that was because she was nearly 11. And at the time, I do not remember one single lecture talking about immunotherapy for food. We've had it for years for pollen and dust mite and pets, for instance, but not one conversation around food. And now that I've got more specialists and obviously have my own clinic and I'm involved heavily in immunotherapy treatments, and I start to go to conferences in America and hear that they've been doing this for 15 years, I feel quite frustrated about the limited conversations going on around this in the UK. So I'm really excited when you say people are ringing the helpline and hearing that there are options, because what I find is that allergy patients and their families are strong drivers of change in the UK. They're really passionate about this topic, as they should be. And I'm hoping that with their support, these things will bring change to the UK. But there is data going back over those years. So the oral immunotherapy, to define, that's got quite a lot of data. We've got Palforzia, which is peanut immunotherapy using a licensed product, Palforzia, which are capsules you open that essentially have very measured amounts of peanut flour within them within a stabilizer. There's big studies around that. There's lots of data that the Americans and others like Canadians have published around oral immunotherapy for other foods. And then the newer treatment that we're seeing emerge, the sublingual immunotherapy, which we'll touch upon shortly, is also got data around it, but probably spanning around sort of 4 or 5 years. So less information around that. These trials often don't have large numbers of people in it, but there is data there, and there is certainly personal experience there.
Great. So who is it most appropriate for? So you speak a lot about children, and obviously how when children are younger, their immune systems are more able to adapt and develop that tolerance. So is it suitable for children with any allergy, or would it be more suitable for children who perhaps have a history of more frequent anaphylaxis? And also then with adults, is it suitable for adults, and is there some data there? And is that going to potentially be something that can come through in the future?
Okay.
There was a lot there, sorry.
There was a lot. Like everything to do with allergy, there are a whole heap of myths around immunotherapy, with a lot of people being told that, well, there's no point in your child having it because they're multiply allergic, they've got too many allergies to target. Or maybe their allergy's too severe, or they can't have it because they're too allergic. And none of that is true, frankly. Yes, if you've got a child with 20 allergies, it's going to take quite some effort and time to try and create this state of desensitization or tolerance for the foods, because we don't treat 20 foods in one. That would be probably too much to try and work through. But essentially speaking, most people can have immunotherapy. The exclusions we have very strictly are if they have asthma and it's uncontrolled, then either immunotherapy for pollens and dust mite or for food is not going to be something we put them through, because there is a risk of anaphylaxis from treatment. And that is more likely if their lungs are poorly controlled. So the first step we would be taking is making sure their asthma is really good. If a person has a condition called eosinophilic esophagitis, or we refer to that as EOE, that is referring to a condition about the esophagus, so the food pipe. And for some allergic people, they have this condition in its own right. And for some, it is a less common complication of oral immunotherapy. Now, what that would give them is symptoms of feeling of food getting stuck, quite severe reflux that's not really improving with medication, indigestion, vomiting episodes. The only way of diagnosing that is with a camera test down into the food pipe and biopsies. Now, if they've got that, if it's not controlled, they can't have oral immunotherapy. And many of us may be hesitant about offering oral immunotherapy if they've got eosinophilic esophagitis, even if it's controlled. However, sublingual immunotherapy is definitely an option for them. And then we wouldn't offer it to somebody who is on immunosuppressants. So, many of our patients have difficult eczema. So, for instance, if they're on methotrexate, cyclosporin, we wouldn't offer it at that point because there's lots of unknowns with that. We would, however, offer it if they're on dupilumab, which is also referred to as Dupixent injections for their eczema. It would work with that one. So those are broadly the outline. And then, of course, there is taken into account what's their other medical history, particularly if we're talking about adults. Have you got uncontrolled heart disease? I'm not going to be overly happy about offering it. Have you got active cancer? I think these are some of the challenges with adults. They start to develop more health conditions. There's also a big query for adults of what do you do if it's a female, and if they become pregnant, what do you do on oral immunotherapy? Because, will that pressure that's now being put on the body potentially trigger a reaction? So there are definitely considerations. There's also, a lot of my consultations, they take a long time, thinking about the person in front of me. Are they going to be able to eat this food every day? Have they got taste aversion? Have they got restrictive eating patterns? Are they neurodiverse? Is this going to be very difficult for them? Where's their anxiety levels? And the parents' anxiety levels? Are they going to be able to introduce this into their diet and cope with the potential that it might trigger a reaction? So it really is person specific, but definitely it's a myth that just because you've had anaphylaxis or severe anaphylaxis, you can't be offered this treatment, because frankly, Mary, most of the people I treat have anaphylaxis, as in they come to me with a history of anaphylaxis. And also there's no such thing as a mild allergy. So, that's not going to rule it out. So if you have an IgE allergy, so the ones that when you eat the food, it triggers symptoms within minutes to hours of hives, swelling, vomiting, diarrhea, possible anaphylaxis, those are the allergies we're targeting. So we can't treat delayed non-IgE allergies or FPI allergies with immunotherapy. It's for IgE allergies. There is much less data around adults. So I do treat adults, but I definitely say to them, there really isn't as much data for you. And one of the big challenges for adults is a little bit around motivation, I guess, because, adults are very well used to navigating the pathway of living with these allergies. And immunotherapy might come with it changes to their lifestyle, potentially multiple appointments, risks of reactions or risks of side effects. And there might come a point for some adults where, let's say they're treating their milk allergy and they keep getting abdominal pain, stomach pain. They might go, do you know, I'd rather just live as I was and just avoid. So there's the element of when adults are included in studies, there's a higher dropout rate. And in part because of those issues that they just think, actually, I was all right with living with it. Also lifestyle, they're busy, might have children, work. How are you going to make the time? Where are you going to travel to? And then other things crop up a lot more for adults: illnesses, hospital admissions, pregnancy. And so when you look at adults included in studies, it can be successful for them. And if you define success as desensitization, being able to eat, say, however many peanuts a day, but will they maintain it and keep up with it because of all those lifestyle reasons? And so I really, when I'm working with adults, work out how strong is their motivation? Do they understand fully what's involved in the processes? And then allow them choice to make their own decision.
So yeah, I guess it depends on their priorities, and if you had someone whose allergy is really affecting the quality of their life due to anxiety and worries around eating foods, eating outs, going on holiday, etc., then perhaps they might be more committed to the
Yeah.
treatment, because it's obviously not an easy process and it's something that takes quite a lot of time.
Yeah, totally.
Um,
And I think, you know, well, we know sadly, and obviously at Anaphylaxis UK, we do a lot of work around people's anxiety levels with our psychological support, because we know that the reality is that the majority of people living with allergy do find it affects their quality of life and impacts on that. But we also have to weigh up for that adult who's at home, who's going to help you make this dose. You're going to have, say, peanut or milk or sesame or whatever we're treating in the house. Can you do that? Can you physically eat this food or put it into your mouth? You can't underestimate the psychological anxiety that also comes with immunotherapy, which is why we work closely in our unit with a psychologist to make sure that they're fully supported to do this and assess, is this the right person for treatment, because of all of those psychosocial factors, really.
so Helen, could you walk us through the process? What is the typical protocol? How long does oral immune therapy usually take from start to finish? And what does kind of everyday life look like for someone who might be going through oral immunotherapy?
Okay. So if we think about, because I've already alluded to the fact there's two treatments, broadly speaking, there's oral immunotherapy and sublingual immunotherapy. Let's talk about oral immunotherapy because it's what most people know of. So first of all, there's huge variation in what each allergist might offer here in the UK, in America, in Canada, in France, in all the different places they're taking it. But most of us in the UK, what we do is we obviously assess are they appropriate, and then we start with a dose of, we call it a dose, in part because we don't want children going around telling everyone they can now eat the thing we're treating so that they don't eat too much of it. But let's say a dose of peanut. We choose a starting level for them where we know most people won't react, because that's quite tricky to do, because unless you've had a food challenge, most people will not know how much of that food they could actually eat before a reaction occurs. And in the case of peanut, around half of people would actually be able to eat half a peanut without a reaction occurring. And if people knew that, they might have a lot more confidence around managing their allergy if they knew it wasn't, teeny tiny amounts. But we choose a level where, for me, around 5% of people may actually have a reaction. So not the level where no one will have a reaction, but we choose a number where most people will be fine with the starting dose. And in part, the reason we choose at that level is because if you go smaller and smaller and smaller, you can imagine you're going to end up with a lot of appointments if we're starting on minuscule amount. In some American clinics, that is what they do, but it just takes longer. So we start with, let's say, 5 milligrams of peanut protein. Sometimes we start even smaller. It all depends on the story I'm being given by the person. And they would eat that supervised with us in clinic so that we can monitor, has an allergic reaction occurred? And on the whole, if that dose isn't tolerated, the commonest thing I see in clinic is that they vomit. And then we go, okay, this dose wasn't tolerated, and we're going to have to bring a smaller dose in to try and make sure that really what we're trying to do is get under the body's radar before a reaction occurs. And that is completely different from person to person. So we're trying to find what's the right starting dose for that person. Now, for an older child, a teenager, they'll feel nervous, but they can be on board with us at understanding, okay, I vomited, but it's because we need to go even smaller for you. Whereas if you've got a 2-year-old and you've made them feel unwell in clinic, it can be quite tricky to keep them on board with, like, trusting you eating that food in clinic. So the first appointment can sometimes be the hardest one to get that dosing correct. They then stay with us supervised for an hour. And every time they have a dose of oral immunotherapy, we have some rules around it. So the specific rules are around exercise. So for 2 hours after the dose, they can't do anything which raises their heart rate. So nothing above their normal activity level. And many of my patients are worried that that means they've got to pin their child to the sofa and strictly cannot move. And I can assure you, if you come to a clinic with us, it's pretty loud, manic, fun, they're happy. None of our kids want to leave our clinic. It's busy. It's not being dead still. It's just, you're not going to go off to football, netball, swimming lessons for those 2 hours afterwards. But they stay with us in clinic for an hour, and then we let them go. And for the second hour, they just need that quieter time with it. Some of our families, if they're feeling nervous, will sit the 2 hours out. But on the whole, most people will have started to react within that first hour if they're going to. They then go home and they consume that amount every single day. So for instance, if we were doing peanut, we put whatever food substance we're using and we tend to mix it in with something like a yogurt or fruit so that it doesn't go directly into their mouth. And in doing that in the starting doses, it reduces any side effects of oral itching or tingling that might put that child off then eating the food. Because if they're putting something into their mouth and it's giving you an itchy mouth, they're going to start refusing the dose, especially if they're too young and they don't understand what's going on. So they have 2 hours downtime. They have 2 hours after the dose where they can't get too hot or cold. So no hot baths or showers. I had a person who sat by a hot fire and came out in a few hives. So, don't go out in the snow. We have dosing around if they're sick. So if they're fever, vomiting, diarrhea, not eating, they would miss a dose that day. If they're overly tired, we'd miss a dose. If you're traveling and it's all got chaotic, we'd just say miss a dose. So if life is too busy, miss a dose. But generally, they do that then every day in our clinic for at least 2 weeks. Sometimes it can be longer. And in that time, most days they need to have eaten it so that we can then move to increase the amount the next time. So when they come back in 2 weeks, we give them a bit more and we follow a protocol. And it really depends, Mary, on what you're treating as to how long that takes. With Palforzia, if I give a brief overview of that, because it obviously is the licensed treatment in the UK, the starting appointment is a very long appointment. It's sort of 3 or 4 hours. And the first dose they're given is 0.5 milligrams. So actually, nearly everybody wouldn't react to that. But then after half an hour or so, they're given 1 milligram, then 1.5, then 3, then 6. And that actually is a cumulative dose of 12 milligrams. And some people by the end of that will have got some symptoms. And sometimes I stop dosing earlier because they will have got symptoms. And actually, when they go home to dose, they only go home on 3 milligrams. But it's only Palforzia where we have this start where you start small and build up over the course of a day. But that appointment takes, to be honest, probably more like 4 hours. And that's a big chunk of time in running a busy clinic to build up a starting dose. Whereas if I'm treating a younger child with real food, so many of us use Bamba, there's a published protocol around that, they're like peanut puffs. You can start on just a smaller set amount and most people would be fine with it. And yeah, so in the instance of Palforzia, it's a 6-month treatment process. And by the end of it, most people are able to eat around 2 peanuts. For our younger children, the peanut immunotherapy would take about 4 months, so 8 to 9 appointments. Same for sesame. Things like treating milk and egg, that's a longer process, so often around 8 or 9 months, because you're building up in those instances to higher quantities of food so that they can incorporate it into daily eating. It seems quite complex, but actually when you talk it through and you see the protocols in clinic with us, you do get a sense of, okay, I'm coming back and forth every 2 weeks or so to slowly expose my body to increasing amounts of what it's allergic to, so that by the end of it, that child or adult can eat a bigger amount without a reaction being triggered.
Okay, so in children then it might take around 6 months, or does it depend on how old they are?
It depends on the food you're treating and how low a starting dose we do need to do. And then the other variable within that is what is the end that that person's trying to achieve. So in terms of Palforzia, what most people do is they aim to get them on around 1 or 2 peanuts. So that's about 300 milligrams of peanut protein. The reason for that is the Palforzia data showed that if a person consumes that daily, in time, so after sort of 6 to 12 months, they're actually likely to be able to eat a whole lot more peanuts. So more like 12 to 20, they've got 12 times more, a higher chance of passing a food challenge. So being able to eat, say, around 20 peanuts, for instance. So just by eating 1 or 2 peanuts a day, your threshold can rise even higher and you can eat about 20. And that works really well because, to be honest, most people do not want to eat peanuts every day. If you've avoided it for a long time, they don't like the taste of it, and it can be a real battle to get them to eat the food. When Americans, families talk to, they often refer to free eating. What happens in that process is we've built up the level of protein they can eat to a lot higher. So now rather than stop at just being able to eat 1 or 2 peanuts, which is about 300 milligrams of protein, you continue with appointments. So now after 2 weeks, you increase it to say 500 or 600 milligrams, and then in 2 weeks, a bit more and a bit more. And you need to get them up to 6 grams of protein. That's a lot of food substance that you've got to try and make your young person eat every day, or even as an adult, particularly if we're talking about maybe a 1-year-old. And when you get to that high level, then we can safely say, right, you can eat as much as you want as long as you don't go over it. And if people really want to do that with us, they can. They can just build the quantities up higher and higher and higher, and that's absolutely fine to do. But it does make the journey a lot longer. And I think you have to argue that if eating 300 milligrams of peanut protein a day after a year takes you to the same level as building up every fortnight to 6 grams, but with all the challenges that might bring, what's the point? Unless you really want this in your daily living. And that's why for milk, we will get to much higher quantities. Actually, most allergic teenagers do not want to eat milk regularly, but some do want to have pizza with their friends, or cheese, or baked milk in a cake, for instance, without worrying at a coffee shop, or, so it really depends on the individual family and person's desire in my clinic as to where we get to the end point. So we are open to getting to free eating if people want to do that. And many clinics now are starting to say, what is it you want to do? Because this is individualized. It's not blanket. Everybody's different. What level do you want to get to? Most people just want to get to a point of safety. That if some fool gives me peanuts or milk or whatever we're treating, I'm not going to have an allergic reaction.
Yeah, absolutely. So when they are having the immunotherapy treatments and they might get some side effects, do they take antihistamines?
Yeah, it depends on what the side effects are, really. So commonest side effects I see are an itchy mouth, maybe a few hives around the mouth, particularly in younger children, or perhaps some lip swelling, particularly if, say, your yogurt that contains sesame, for instance, has lingered on your lips. You might get a little bit of lip swelling. Tummy aches, those are the commonest things. And actually what works really well in those instances is some antihistamine, often cetirizine, usually 30 minutes before the dose, and that blocks the histamine, so it blocks the reaction. It doesn't mask anaphylaxis, and in real life, as in when you're exposed to an allergen, it doesn't stop anaphylaxis occurring, but it helps build tolerance. And what I tend to find then is into the second week of dosing, you can stop the antihistamine and the side effects have gone. If that wasn't working or we were having problems, you can simply go back a dose, go back a strength if you like, and stay there for 4 weeks, 6 weeks, 8 weeks. Going longer and slower will often get rid of the side effects. There are sometimes other medications that we use as well. And it can sometimes be a challenge to work out, is this actually a reaction, or is this a young person with a lot of anxiety getting abdominal pain? And I have had a young person stop because really their anxiety levels became so large that it felt like the treatment for her was worse than living with the disease. And, we all came to an agreement that this just wasn't right for that person. And we've supported them, to just continue to live as she is for now. And we can come back. There are other things. And as I say, there are this other treatment method that we could use instead. Now, obviously, if you have anaphylaxis, your treatment is going to be adrenaline. And anaphylaxis can occur with rates sort of varying of 3 to 10%, depending on which studies you read. It's definitely not everyone that has anaphylaxis, but it also is some. I do think that if you do enough oral immunotherapy and you include most people within that, most age ranges, you will see anaphylaxis occurring. That is the reality. And that's why some allergists don't like it, because it contains risk with it. But the benefit it brings to people's quality of life is what I find life-changing and why I absolutely love my job. But obviously you're going to use the adrenaline auto-injector, and then afterwards we're going to have a conversation of what happened. Sometimes it's very clear. I had a young lad, lovely, but went to a very vigorous football game within the first hour of treatment. It wasn't the most sensible thing to do, and it did trip a reaction. He definitely learned from that wasn't something to be done. But if sometimes anaphylaxis occurs and there's no obvious reason, they're not sick, they didn't exercise, they were really good and followed all the rules, and that is the hard thing. Sometimes it happens. So if everybody's still on board, what we would do is drop the dose down, stay even longer, however long that is. Some people I've got dose every sort of 4 to 8 weeks, and then we go again.
So in clinic, you talk about using, the peanut puffs. And so are people just taking those puffs, the amount that you've given them, and eating them? Are you turning foods into solutions? How does it work with the actual format that the food is in?
Yeah, so again, really depends on like what food we're talking about. We use basically in my clinic, I use real food. That's how we treat the allergies. So, eventually with peanuts, we might start on peanut puffs, but sometimes we start on a powder and then we move to real peanuts. If we were treating milk, clearly it's milk. If it was lentil, for instance, we use lentil rice, and then we can use pastas, and sometimes we can even use crisps. To begin with, we mix it within a yogurt or something because it helps reduce that oral itch. But by the end of it, they can just eat the food. Now, obviously, if you've got a little child, choking risk, you're not going to give them whole nuts, but they might use peanut butter by the end of it, for instance. So they just eat it. So it really is just using shop-bought products, using it. But we have to be mindful because we are using that to treat a condition. And therefore, that is seen as giving a medicine, even though it is actually a food. And that's why it really does come with lots of support, control, making sure that, for instance, the food we're using has got stable protein content, that it's not changing. So we teach our families how to be checking that on packets to make sure we're not getting muddled. We talk about sublingual immunotherapy, so we can talk about the solutions. So sublingual immunotherapy is a newer treatment that is becoming available within the UK, with more centres beginning to offer it. And I do think it's the future personally, but we need more data around it. So in America, where they've been doing it, and in Canada, some of them will use grocery products again, where you dilute it down. So let's say we've got peanut powder and we dilute it down with distilled water, and that makes it into a solution. Or many nuts come as a milk. Cashew milk, for instance, comes as a milk, so we can dilute the milk down and use that as a solution. Some of them will use essentially the skin prick test solutions, for instance, to do an allergy test. Some of them will use the extract of that in places like America or Canada to treat the immunotherapy, but that comes with a cost because it's now a medication type product you have to buy. It's not a medication because it's for a test. The premise of sublingual immunotherapy is the drops of the solution go under their person's tongue. They hold for a minute and then they swallow, and then they don't eat or drink for 5 minutes. And as I say, this is something we've done for years for grass pollen, tree pollen, house dust mite, with NICE, the National Institute, approving recently a Acarizax for house dust mite, Itulazax for tree pollen. We have Grazax for grass pollen. So we know that it works for those things. And there's a slightly different mechanism with sublingual immunotherapy. So it's being taken up by the mucosa, so that's the kind of tissue under your tongue, and presented to the immune system in that way. And what we believe happens over time is that there's an immune system shift with both oral immunotherapy and sublingual immunotherapy, meaning that the T regulatory cells increase. So they're the ones that stop allergic reactions happening. And the cells that trigger allergic reactions, they get dampened down. So you have a shift in the immune system to build more tolerance and prevent a reaction occurring. And we see that with sublingual immunotherapy too. So with sublingual immunotherapy, you tend to work through a few doses. And the beauty of it is you can start really, really tiny, like 0.1 milligrams as opposed to, say, 1 milligram. So that if you've got someone who's had a really difficult history of anaphylaxis with, say, intensive care, or really nervous, or maybe for me, the adults where, there's less data around them, you can start on tiny, tiny doses. And generally every 2 to 4 weeks, they build through the strength to get to an end dose of about 4 to 6 milligrams. Now, as I sort of alluded to in Palforzia, the peanut immunotherapy, they start at 3 milligrams. So essentially for sublingual immunotherapy, your ending dose is often the starting dose for oral immunotherapy. But despite that, some people do still get side effects like itchy mouth, tummy aches. The beauty of sublingual immunotherapy is there isn't really any downtime after the dose of it. They don't need this 2-hour restriction after dosing. And the risk of anaphylaxis is probably around 0.2%. So not nothing, but much, 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 much lower. So they dose to the top strength of, let's say, 4 to 6 milligrams. And they do that every day for a year. And then after a year, we would bring them in to do a food challenge to see, can you eat some of this food? So it's a longer, slower process to create change. But it is really fascinating with, again, the most studied one being peanut. And in the study, there's a study where Kim et al. Have a look at 1 to 11-year-olds. Now, I would argue 1-year-olds can't do sublingual immunotherapy. I don't believe that any 1-year-old is holding a solution under their tongue for a minute. But what they are probably doing is swallowing very, very tiny amounts. And after 4 years of treating, 89% of people were able to eat 9 peanuts just from having a teeny, teeny, tiny amount with very, very low risk into their body. And for me, what sublingual immunotherapy does, Mary, is says to me, the position we are putting UK children and adults in of just avoid it safer is just so frustrating. It is not safer. If we had tiny, tiny amounts in their diet, we might create change. But I caveat that with there is not many studies, and there are definitely even fewer studies in adults around this position.
Sure. It'd be good to talk about what is available right now for people in the UK, particularly through the NHS, because so many people come to us and say that they just get turned down from their GP or from primary care. So yeah, it would be great to kind of clear that up. What is available, what types are available, and when might it be more widely available in the UK through the NHS?
Yeah, because I think one of the biggest, tragedies we have right now is that many people leave the UK to go to places like America to actually dose. So I would argue with you that it's not really GPs turning you down, it's actually your consultants turning you down, because to be fair, many GPs will not have heard of immunotherapy for food because it isn't widely being used. So unless they're specialists like me and have done more, work and we're interested in this area, they wouldn't know. Although sometimes GPs will turn you down for the immunotherapy for pollens or venom, so bee and wasp stings, when they maybe shouldn't, because that is available on the NHS. So on the NHS, we have sublingual immunotherapy or subcutaneous, which are injections for grass pollen, tree pollen, house dust mite, and bee and wasp stings. So that's, in a specialist centre. You've got to hit criteria to have that. In terms of food, it is really tricky, and there is a bit of a postcode lottery going on right now. So Palforzia was the licensed product. NICE gave it approval many moons ago now, which meant it was meant to be offered. But because of the challenges of how time-consuming this is, it isn't being offered because, frankly, many allergy centres can't even cope with the demand to actually see, assess people and follow them up. And that's why it's really hard to say, well, this one person with a peanut allergy will treat, but there's a child out there with 20 allergies that we can't even assess yet. And that's why it's really challenging for allergists. And I'm sure many allergists would love to offer these treatments. They are, of course we want to help people, and it's brilliant and life-changing. So there are a couple of centres that offer Palforzia. So I believe Norwich does. I think you might find some of the London hospitals do. Trying to think who else. Do you know, Mary? I think that basically is it. I can't think of anywhere else off the top of my head that's offering Palforzia. Get some places doing some form of oral immunotherapy for milk and egg at home dosing. So Birmingham do that, Leicester do that, Hereford do it, a bit of London do that as well. That's it, Mary. That's the sad state of it. That's it. So if you are a person that's got a pea allergy that is finding that incredibly hard to navigate, as we both know, it's an increasing allergen, it's really difficult, you're not going to get help on the NHS for it. And
through private healthcare, what foods can you have immunotherapy for?
So privately, there are only a few of us doing it in the UK and Ireland. So you have my colleagues, so Professor Fox, Lack and Twat doing it in London. And they have a couple of centres, and they will offer immunotherapy for children, so 0 to 17. I mean, we wouldn't do it in teeny tiny babies, but when they're big enough to eat and use adrenaline if we needed to. I believe that's their upper end, but of course they might change, but they do mainly do paediatrics. My colleague in Birmingham does peanut, milk and egg, and I think that's mainly it at the moment, so that's Nick McQuarna. And then in Scotland, Adrian C does a bit of Palforzia at the moment. Palforzia and peanut. I'm trying to make sure I don't miss anyone out. I obviously have a clinic in Belfast and Ringwood, so as far as I'm aware at this point, I'm the only person doing children and adults, but I'd like to think that will change. Helen Broth does some patients as well in London. She tends to do under 5s, I believe.
Okay. So if you had a child who had a serious allergy to pea or legumes, could you get private immunotherapy for them?
Yes, with either me or London.
Okay, so there you can cover quite a few different food types. The top 14, would they all be on there? Or, the major, more common ones?
Yeah, so I think the reality is immunotherapy can be developed for most things because you just have to know like what's the starting dose and you build it through. It is tricky for fish and shellfish, so none of us are offering it for that. But I'm going to miss the food off. But we will do it for wheat, egg, milk. So that's obviously your main sort of ones that people find tricky. Peanut, sesame, all the tree nuts. So hazelnut, cashew, pistachio, Brazil, walnut, macadamia. Coconut, mustard, pea, lentil, chickpea. I think those are the main ones. But, let's say somebody comes, or pine nut. If someone comes and says, Helen, my child's got a sunflower allergy, this is really challenging for us, we really want it treated, that's fine. We can help you work out how to treat it.
Sure.
You can do it as long as we can work out a stable protein content from the food and make it up. Now, the sublingual is harder because you need a food that's either in a powder or a liquid. So, if you've got a milk, perfect. If you've got, you can get walnut flour, you can, obviously wheat comes as a flour that works well for that. But, treating something like beef, for instance, is going to be quite tricky because there's not brilliant beef flour. What I find with the Americans is they have a lot more products available. So they have, I've been out to a Florida clinic out there and they did treat prawn with sublingual immunotherapy, smelt like goldfish food because they did have like a powder that came for the prawn that you could buy, like shrimp powder or something. But yeah, you can develop it if your allergist is willing to help support you. But you then have to be mindful that there's probably less studies around that. We'll have less data for you.
So do we know why medical insurance companies aren't covering food immunotherapy? And if you think that's something that they might consider doing in the future, is it because it's still something that's up and coming and currently there's a lot of research going into it? So is that maybe why?
Well, I mean, Palforzia is licensed, isn't it? It's got nice approval. It should be offered for somebody's insurance company. And certainly like the Americans, the reason that many of them will be offered oral immunotherapy is because they can reclaim it through their insurance. They've obviously got healthcare. Do I see it changing? I don't know. The cynic in me says probably not, because I think that, it is quite an expensive process because of the number of appointments that are often needed and the support is sort of, wraparound support that we give these patients and families. And I suspect many insurance companies will write it as an exclusion. I don't know. I could be wrong. It may well change in time, but we'll see.
Hopefully. So when people have oral immunotherapy privately or sublingual immunotherapy privately, why is it so expensive? I mean, you've obviously discussed how complex it is and, one size doesn't fit all for people with allergies. So yeah, I think people often do ask us, how could we afford that? How could we afford to have immunotherapy? And it might just be good, if you could just explain why. Yeah.
And there is huge variation in cost. I mean, within the UK, it's relatively stable. But if you look at, some patients traveling, for instance, to California, some of these things are lots, like 30, 40,000 plus. And of course, all your travel time. It's not quite that bad in the UK. So there's lots, I think, that go into running a clinic that until I did it myself, I had no idea. You've obviously got all your business running costs, which are expensive for individuals. And these things from our perspective come with very high insurance costs because this isn't something being done a lot. And it does have a level of risk. As soon as you say to an insurance provider to cover me, I might give this child might have anaphylaxis from this treatment. My insurance, is going to be up there at sort of 20, 30,000 a year. So there's those costs, but it is around the fact that, if you are doing an in-clinic dosing, and we do a mix, to be honest, of clinic and home, then every fortnight for 4 to 6 to 8 to 12 months plus, you're going to need staffing supervision. So we need the space to be able to do that. And, people need to be able to contact us out of hours to ask help, because whilst the premise of immunotherapy is pretty straightforward, give that person increasing amounts of food, there are so many nuances and hurdles that crop up in the journey that, even I keep discovering, like, oh yeah, I didn't think about that. And that, that we are there to help you. So some people, it's so straightforward and easy that the family at the end are like, oh, are they even allergic? And you're like, well, we were. And we often see that because like, well, yeah, remember they reacted at dose 1 and we've managed to push them through and there's been no bother and it's been really easy. but others where, you're needing multiple touch points. And so I know it's expensive and that is hard for families, but it's because of all of the costs that come of running a clinic, needing high staffing levels, and because, you're having a lot of appointments. So if you think about the cost of your hip surgery, but you've only got like a couple of appointments within it, it's balancing that off that people don't understand. And it's why it's so hard to offer it in the NHS, because you're going to need to be able to speak to your allergist frequently if you need help. I'm constantly getting messages on a Sunday, little Johnny has got a fever, what shall I do? And although they've got clear guidance, families just want to double check with you until they build the confidence. And that's quite right. We'd rather they check with us than not.
So how do you see it kind of rolling out in the UK? What's being done to improve access or to, one day hopefully make it more accessible for people through the NHS?
Well, I think so there's two things going on at the moment. Obviously, the Natasha Foundation are doing some of the biggest trials in the UK for milk and peanuts. So I know that everybody out there with other allergies is slightly frustrated, but it's because these are the most studied. And so I guess you've got comparative data to show that this works. We know it will work for most foods. And on that, they have an in-clinic dosing and a home dosing arm. And I believe that there's very little difference between them. And that would be my personal experience, Mary, of treating now, a lot of children with immunotherapy and young people. So I've done this now for around 3 years. I know this is hard for families to know. It isn't usually in clinic that they have anaphylaxis. It often is a bit later because maybe the rules weren't followed, or sometimes, as I said, just because it is. So actually, there's an argument that once you've got that right starting dose for that person, and you are certain that it's the right family, that they're motivated, that they're keeping that child safe, that they're following the rules. So for me, that takes like 2 or 3 appointments to know that I'm happy with what you're doing. You could potentially do some remote dosing. And I think if we look to Cork, so obviously the Republic of Ireland, they actually now on their HSE, so it's like their NHS equivalent, are offering oral immunotherapy for the under 5s for peanut and tree nuts on their NHS equivalent. So they have one appointment in clinic and the rest is all remote. And I see that is probably one of the only ways we're going to see change coming to be able to have capacity to manage this. And maybe also with some of these other newer treatments I'm talking about, like sublingual immunotherapy, where it's lower risk, less appointments. I think that will have the change that we need to see. But how long is it going to take?
Well,
that's my opinion about it. Because it is, we should, I'm so passionate about this. We shouldn't be in a position where we say, here's your diagnosis of food allergy or even environmental allergies. Just avoid. There are treatment options, and it's so unfair. I'm so passionate that we should have more access to this within the NHS, and we need to be lobbying government to find that money to help us create these changes in the service.
Absolutely. So what is the success rate generally for OIT or SLIT?
So when I asked somebody this a while ago now, they said to me, well, it depends what you mean by success. And I thought that's such an annoying answer. But it is a bit of, what do you mean by success? Because, for instance, I have a lovely young person who we treated with palforzia. They had absolutely no problems. We transitioned them over to peanuts. And it was at that point that the young person had anaphylaxis. And she chose, because she was old enough, that she didn't want to continue anymore, which was perfectly reasonable. So do you count the process a failure or a success? Because we did actually go through palforzia, and there were things we could have done to have continued the dosing, and probably the longer and longer she got down the line with success. But for her, it didn't feel right, and we absolutely have to support people to do what's right for them. And if I have a person who's got the ability to choose for themselves in clinic saying to me, I don't want to do this, I'm not doing it, because they have to continue dosing lifelong. And if they stop, it's just a complete waste of that parent's money, and it's going to be a battle. And it's, I've got teenagers, it's no fun trying to make them do anything. Anyway, if I ignore that roundabout of what do you mean by success, quoted figures are around kind of the 85 to 90% of people that we will manage to desensitize. Now, that doesn't mean with no reactions. And the reasons that people stop dosing are things like reactions that they don't want to carry on that risk, side effects like abdominal pain. That's definitely something I see. I've had one young person who could not stand the taste of it, and it did trigger a reaction because of the tantrums that were thrown from eating because she was only little. But she is having sublingual, and it's much easier because the taste is, much less, and it's quick and it's done. Finding the right starting dose. Some people, as I say, their confidence is gone and they don't carry on. But if I look to my American colleagues who are much more experienced than us, they say that some people, despite the, different OIT protocols, sublingual immunotherapies, even Xolair, which we haven't really talked about, but injections to reduce their IgE levels, some of them still react and we can't seem to desensitize. And I think what's really, really important is that we give even more support to that person and family and adult if that is the case, because actually being left in I don't have any options, I know that I'm now this reactive, that can feel really hard. And I think it's mindful that we use correct language to not make them feel like that's down to them and their sort of them being a failure or them not having the willpower to keep going, or because I have some teams that struggle and they want to do everything they can to achieve it, which I totally understand, and they think it's a reflection on them if they can't, but it's not. It's our bodies, and all illnesses sometimes are in a state where we've got all these medicines but not everything works for everyone, and that's why we need to keep researching, keep looking at other options, keep looking for that elusive cure.
Thanks, Helen. I've had a few concerning calls from the helpline since I've been here about people who say, oh, well, can I try and microdose, or can I try and introduce my allergen myself, because they hear about oral immunotherapy and think, oh, it's just a gradual increase. So I just thought it would be good to cover why that is absolutely not recommended and why that is a dangerous thing to consider.
Yeah, I have those stories too, and I have people come into clinic who sometimes have tried that. And look, the reality is for some people, as I say, it's relatively straightforward. If you found a protocol and it worked and, you have no bother, then you're going to be winning. But there are so many nuances of oral immunotherapy. And if your child has a big reaction, who's supporting you in hospital to say, what are you actually doing here? This isn't with medical advice. And have you put your child in jeopardy? And I don't want to scaremonger, but, to be a bit careful about the safeguarding of, did you really know all the rules here? The bits that I haven't had time to explain on a kind of 1 hour podcast of whether you should or you shouldn't be dosing. And I'm not saying that just so people can come privately, because I would like to see this more mainstream on the NHS. But I do a lung assessment for everybody. They all have respiratory assessments. Just because you think there's no asthma, sometimes there is. I found people where their lung function was not good and it was sort of quite hidden. So if they start having reactions, how are you going to do that? What about when they start refusing doses? How do you know how to mask and change and go down? And because a Facebook group will only give you so much support, at the end of the day, this is individualized healthcare. And what we also really don't want, for many reasons, is somebody to die. Obviously, for the primary reason of we don't want anybody to die. That would just be catastrophic. But it also will throw massive doubt over immunotherapy and that ability to keep these options available for everybody else, let alone how you'd feel if that was the case. So you really, really, really need support. So I do understand it, because if somebody's feeling like I can't afford it and I want to bring benefit to my child, but in that situation, you have to do a risk-benefit weigh up. And the risks are too high because you could cause harm to your child.
Yes, exactly. And then there's, a lot of safeguarding issues there if something happened to a child who you had given the food that they were allergic to. But it's so difficult, I think, for people because they really want some help, but they just can't access it. So we've also had people saying, can I sit outside A&E and eat a little bit of the food that I'm eating to try and figure out if I can actually have, a small bit, or if I can't have any of it. And those sort of questions do crop up every now and again, which is understandable because people are trying to figure out what to do and trying to get some help.
But we have to remember that sometimes anaphylaxis is catastrophic despite the early intervention and use of adrenaline. So I like to give proper statistics to help support people, because this is a topic people listening, they're going to know that this creates a lot of fear. And thankfully, dying from anaphylaxis is extremely rare. But we only need to look at, say, for instance, somebody in the last couple of years who died from an anaesthetic. They were with an intensive care, with an anaesthetist at the time. They couldn't have been in a better place. They would have had everything available to them. And sometimes those reactions are overwhelming. How do you know that the first bite is okay? And of course, a lot of people come to me in clinic with that real stress of how do I know? But we know a measured protein content, which is really so low, so that the likelihood is what we would see is a vomit or a tummy ache. But that doesn't mean anaphylaxis hasn't occurred with, say, some of my colleagues, and probably is just a matter of time before I see something. But we've given a really tiny amount, and we are imminently, we are right there. So I really understand, and I think it's it's because people are just being left to it. Of course, you're trying to help yourself or your child. You really are, and it's just not fair that allergy services have so little funding in the UK. It's just not right.
Thanks, Helen. So for those people who can't get immunotherapy for food through the NHS and who often come to us asking if there are clinical trials going on that they can get involved with, do you know of any that are currently going on, or how people can find out more to get involved there?
Yeah. So I think it's always really important to keep in touch with your allergist at the allergy centre you're under, to be asking them, are there any trials I can be involved with, and saying, can you let me know if there is. You're going to find that if you are part of a bigger, what we call a tertiary hospital, so we have like district hospitals, which is likely to be, I live in Dorset, so the Poole and Bournemouth would be what we'd have as a district hospital, and Southampton would be our tertiary service, our big allergy centre where you get more allergists. So most of the allergy studies are going to be done in a tertiary centre. But often you'll find that the individual district hospitals will hear about that because they'll go to meetings. So you want to be on waiting lists. So obviously the Natasha trial is underway, but I don't think that they're taking on or recruiting anyone else at the moment. London is often, a hotspot for where some of this research goes on. So it's kind of keeping an eye. Sometimes at Anaphylaxis UK, we will share if people are being recruited for studies, won't we? You can have a little look on their website, see if you can find anything. I know my colleague in Southampton, I think he's going to be doing some more research around the peanut patch, for instance, that we haven't even touched upon, but the way that we can desensitize through the skin. So I think he's going to be doing that in younger children. I think the 1 to 3, I want to say. So that's at Southampton. Often you need to be local to those hospitals for them to allow you to take part, because they need you to be able to travel back and forth. So looking at the individual centres, if there's emails on the website, email in. If there's any research, please could you let me know? I'd like to take part in it. It's hard because sometimes it's luck of, were you in the right place at the right time? Did you happen to have an appointment with your allergist and they told you about this study that was going on?
Sure. So just to round up, Helen, we've covered lots there. It's been really, really helpful, really informative. So I just thought I'd ask, your final thoughts on food immunotherapy.
So I have to say, in sort of 20 odd years now of being a doctor, being involved in immunotherapy is something that I just find utterly life-changing. I absolutely adore going to work. I, have seen how people come to us so incredibly anxious, like just literally shaking, and how their quality of life has changed over the course of weeks and months, with families sort of being reunited again. But immunotherapy is a journey. There are ups and downs, and we are as much there for people for the downs as we are to celebrate their wins. And what I'd like to leave on is something positive, that although, I know this is going to be a hard conversation to listen to for families who really want it for themselves or their children and perhaps haven't financially got the means at the moment. But I would say that over the last few years, I'm seeing that allergy is getting more attention. We are finding that there's more research being done, more attention being placed on looking for that cure, the Neffy that's come through, the nasal adrenaline spray, sublingual adrenaline coming. It is a time of change within the allergy world. And I really do hope that we will start to see some of it filter through to the NHS as well. So hold on to that, because, these are different conversations we're having now than when my son was born 16 years ago and I was at university and no one spoke about it. So I think change will come.
Amazing. Thanks, Helen. It's been really great having you on, and hopefully we will have you back soon.
Thanks, Mary.
We hope you enjoyed tuning in to today's podcast on this very important topic. To make sure you don't miss any episodes, you can subscribe to our podcast on your favourite podcast app, including Spotify and Apple Music. Finally, be sure to follow us on social media at Anaphylaxis UK to join in the conversation, and let us know if there are any questions you would like us to answer next time.